Dr. Lalit Kumar, guest of honor for the day. Professor Kishan Lal, former INSA president, senior fellows of INSA, guests and students. I welcome you all for this public lecture, which is going to be delivered very soon by Dr. Lalit Kumar, as has been announced already. INSA has been organizing various activities for the last several years, but for the last few years, we have been regularly organizing these public lectures. And in the last few years, we have had distinguished speakers and eminent scientists like Professor T. Ramasamy, Professor Govardhan Mehta, Dr. Kasturi Rangan, Dr. N.K. Ganguly, Dr. G. Padmanabhan, and Dr. S.K. Sareen, Professor M.S. Valiathan, and many others who have spoken to us on different themes related to physical science, biological science, and also medicine. And in this series, the last lecture was delivered just about a week ago by Professor B. Balaram on ranking Indian institutions choosing courses for horses. And so today we have with us Dr. Lalit Kumar. I would just like to briefly give you his background and the distinction he has earned in the field of medicine before I invite him to make his presentation. Dr. Lalit Kumar is presently professor and head of the medical oncology at the prestigious All India Institute of Medical Sciences in New Delhi. He has contributed immensely in the fields of bone marrow stem cell transplantation, treatment of blood-related malignant disorders, and treatment of cancer in women. Born June 30th, 1957, Dr. Kumar studied medicine from SN Medical College, Agra, and later did DM in medical oncology from the Cancer Institute in Chennai in 1988. He undertook a postdoctoral fellowship in bone marrow transplantation way back in 1991-92 at the leukemia unit of Hammersmith Hospital in London, UK. Dr. Kumar and his team have developed a highly cost-effective stem cell transplant program at AIIMS for the treatment of malignant and non-malignant diseases. His team has already performed more than 600 allogeneic and autologous stem cell transplants with results comparable to international standards. His group has contributed immensely on the use of chemotherapy for the treatment of advanced cancer of cervix and ovary. His manual of gynecology oncology is followed widely at cancer centers in India and neighboring countries. Dr. Kumar has published more than 325 research articles in reputed international and national journals of medicine. In addition, he has edited 2 books, 3 residence manuals. He has been a guide to a number of PhD, DM, and MD students as well. Dr. Kumar is recipient of numerous awards and honors. Some of them include Dr. B.C. Roy National Award in Medicine, Ranbaxy Research Award for Clinical Research, ICMR Award for Research in Cancer, Fulbright Nehru Visiting Lectureship, and Commonwealth Scholarship. For his contributions, he was elected as a Fellow of the Academy of Sciences and National Academy of Medical Sciences. Recently, President of India has conferred upon him Padma Shri. So with this background, knowledge, and introduction about Dr. Lalit Kumar, I would like to invite Dr. Lalit Kumar to make his presentation.
Thank you, Professor Khurana, for kind words. My warm greetings to all of you from All India Institute of Medical Sciences. At the outset, I would like to express my sincere thanks to Professor Kishan Lal, INSA, for giving me this opportunity. Now, I'm a clinician, so I'll try to give you a little perspective from a clinician point of view. These days, we keep on listening about sound good. Stem cell is such a hot topic that you keep on listening every second day that stem cells are being used for particular disease and so on. In fact, this reminds me that the INSA had this initiative, Science and Society. So this is something like a famous quote by Albert Einstein: the science without social relevance has very little to recommend it. So I think this is very fitting that we are today discussing something which may be more applicable to the health of the people. While I was preparing for this talk, I actually came across like how the really stem cell field developed. In fact, the word stem cell was coined in 1906 by one of the Russian hematologists, Alexander, in one of the meeting in Berlin when they had a meeting of hematology. But there was nothing, no major progress happened till almost the Second World War. And these are the pictures of Second World War. You can see on your left side. When so much of disaster happened, so much of tragedies happened, the US government really got worried that there's nothing known how to combat the ill effects of the radiation, when the atomic bomb and all these things happen. So they put a team of people to really work on how to counteract, or can we develop something which can take care of some of these things. Number of chemicals, number of things were developed, and a number of scientists who worked, and then they really came out that side effects of radiation can be countered by using the so-called the bone marrow stem cells. Initially in the mouse models, then animal models, and finally in the human trials. And I will come back to you with the same theme again. And some of this aspect has been very nicely depicted in this book, and some of those who may have read this, Siddharth Mukherjee's book, which is very popular, and he was recently in India just a few months ago. And this really gives you account of the last 1 century, how various things have been, the story of cancer or biography of cancer, how the many things have developed, and which also mentions some of these things. Now, let me just give you some basic idea, like do we pointer here on this? Pointer is So this is the basic model of stem cells. Now, what you have the embryo, and you have the blastocyst or blastomere, which is like 5 to 24 cell stage. This is about nearly at the 5 days to 7 days time. When you have these are the cells, you can call them the embryonic stem cells. And they give rise over the time with the different germ layers, what we call them ecto, mesoderm and endoderm, and which give rise to the various organs. If you will notice in the middle from the mesoderm we have the haemopoietic progenitor cell, which give rise to your bone marrow. Now bone marrow is the most versatile, one of the organ which has been studied so far, and it not only give rise to the various elements of blood, which we, but also it can give rise to the liver, GIT, lungs, and also to the skin and brain. And this is the concept which in fact has been used in the past 2 decades or so for the use of bone marrow stem cells for the repair of various organs. And after this concept, people came out with the different names like totipotent, pluripotent, quadripotent, tri and bipotent and unipotent, which basically gives rise to the different kind of tissues where the stem cells are located and the kind of cells which can originate from or they can differentiate to these different cells. So to sum up, a stem cell is a cell which is clonogenic and which can not only self-renew but also differentiate into the different organs. So that's what stem cell is. Now the various terms which you often will find in the different papers and where like people often sometimes confuse actually the stem cell therapy, which is one of the word which you normally use, or sometimes in cell therapy we use it. And second is the haemopoietic stem cell transplant. Stem cell therapy, I'll just little dwell upon it. Now, every organ in our body have the tissue specific stem cells. Okay, whatever the organ we have, each organ has a tissue specific stem cell, and on the top of it, for understanding, you can say there is master stem cell, which I said the totipotent stem cell, which can give rise to anything in the body, right? Now, as a result, with the interest in this field, there are huge number of trials across the North America, Canada, Australia, Europe, and in Asia also. The number of clinical trials in the various aspects of stem cell therapy are going on. Now, some of the work which has been done at the All India Institute of Medical Sciences, it started somewhere in 2005, and which included work on the cardiac related to the brain related, some of the work on the eyes, peripheral vascular disease, liver and skin. And I'll show you some of these pictures. And what we have used at that point of time, only the autologous bone marrow stem cells, because these are the cells which have the versatility, capability of differentiating into the other tissues of the body. And since there were no ethical issues were involved, and there is no question of tissue rejection. So this was pure and simple autologous bone marrow stem cells which were being used for this. The initial work which was started on the myocardial infarction, what we commonly call it a heart attack. So in this, what we did like at the time of cardiac bypass surgery, normally what we do, we generally operate from the sternum. Sternum is splitted, and once you split the sternum, there is suddenly surge of the blood, which is in fact rich in the bone marrow. So at that point of time, we just suck the bone marrow from there and then take to the lab, process it, and finally you will have the small amount into the syringe, and you can just inject around the tissue which is now fibrotic, the myocardium which is fibrotic. So if you inject into this, so the concept is that probably it will help into the healing of these cells, the myocardium, and should help to improve the ejection fraction and contractility of the myocardium. So that was the kind of concept which was given, and in the some of the studies which we did that time with the using stressed thallium, that you could see that from compared to pre and post, there's some reduction in the area of fibrosis. Similarly, the perfusion scans and also the metabolic scans like the PET imaging. So in some area there was an improvement in the viability, there was improvement in the ejection fraction on the echocardiography, and also in the contractibility of the left ventricle and the myocardium. So this was some of the observations which they did publish, but this was a kind of phase 2 trial, and recently they have done a multi-centric randomized trial where the physicians were blinded, so they did not know which patient to getting stem cells and which were getting only the normal saline. So this trial has been conducted at 3 centers, CMC, All India Institute and Army Hospital, and the results are now being compiled and hopefully will get published very soon. So at this point of time, it's difficult for me to say what is the result, but it's possible that we may not, hopefully in next 6 months we probably should be able to get some of the publication from that trial. Now, internationally, apart from the autologous stem cells, you have a variety of other tissues, other cells, which are also used for the same purpose. But this, even the cardiac myocytes, even umbilical cord or in peripheral blood stem cells also have been used for this purpose. Now, many people believe that since you are not able to demonstrate, one of the proof would be that stem cell, if they can get converted into cardiac myocyte, so if you are able to demonstrate the marker for cardiac myocyte, that means the cells which you have injected from the bone marrow are able to really, that they have got converted to cardiac muscle tissue. So that is one of the limitation, and it's believed that probably about 0.1% of the cells what you have injected will convert into the cardiac, that particular tissue, cardiac myocyte. So some people believe that the major improvement, what you see in functional in some of the patients which you are seeing, is probably the paracrine effect because of these cytokines, which are also released at the time of injury into the myocardium. So this is something, one of the area which is being currently investigated. The other interesting work which have been done in the Department of Ophthalmology at the institute, that limbal stem cell transplant. So this is like the limbus, you know, this area which is very rich in these stem cells in the eye. So some of the patients who come with the burn injuries or chemical injuries, and you can see the kind of thing they have, the vision is lost, and if you just take these limbal stem cells, put them in an amniotic membrane, and then put them in the culture for a couple of days, and then subsequently put it there back to the tissue, this leads to gradually the scar gets gradually cleared, and you can see the little eyes become much more clearer, and some vision can be restored. It's not the complete vision, but at least some vision can be restored. Similarly, in another case, the chemical injury, and after 10 months, you can see that at least it's a little much more, and already the similar next case also. So these are kind of the observations. So it has helped some patient at least to regain some vision. Now, liver injury is another area, especially the newborns. Many of the newborns, they are born with the jaundice. And by the time they are recognized and they are taken to the hospital, you'll find that liver already is cirrhotic. So except the liver transplant, there is no other method really to do for these small kids. And so what we have, our group from the pediatric surgery, they took the initiative for some of these newborns. We collected their stem cells from the bone marrow in the newborns. And you know the newborns, the bone marrow, it's basically we collect from the tibia. That's one of the very easier to get the marrow because that's more stable. And compared to the normally in adults, we get from the iliac crest or sternum, some of those flat bones. But in the newborns, we generally aspirate from the tibia and gives you enough number of stem cells. And then subsequently at the time of surgery, they inject it around that area, and they could demonstrate that there was benefit in at least in some of the children, not in all. So another interesting observations which my colleagues from the Department of Dermatology, and what they did that they took the non-cultured the hair follicle outer root seeds, and they put this as a suspension around that area. And what they have been able to demonstrate that in these some cases, in some area, the vitiligo, which is one of the most difficult situation, at least they could, after a couple of months, they could demonstrate that there was able to, the area got little more better pigmented. So these are some of the things which have happened at the institute level, and internationally also a lot of things have been happening. And recently one of the trials just published from the department, again multicentric trial in 120 patients, and for the patients of stroke. Those patients who developed stroke, what they did, they again took the bone marrow stem cells and they injected into the, through the catheter, they put a catheter into the carotid artery which goes to the brain, the branches, and then they injected around that area. And final conclusion in the multicentric trial from many centers, the conclusion was that even though it did not result into benefit, at least the procedure was safe. So this is just published about 2 weeks before. Now, some of you may have seen this picture, Professor Yamanaka from Kyoto University, Japan, and the whole revolution in the field of stem cell therapy came with this concept of induced pluripotent stem cell. And the concept was that so far we were saying that like you take the bone marrow stem cells, inject them or put them into culture and then use them for the treatment. But here you are taking the directly from the somatic tissue, you're from skin or from muscle or anything, and treat them with a variety of cytokines. They had a cocktail of about 4 to 5 cytokines, and they could demonstrate that if you put them into culture, you could convert them back into the specific tissues. And so therefore this is something which suddenly have explored the whole area, and now the whole field, and now people are, lot of clinical research trials and clinical work is now being started in last 2 years. So not only like in the field like diabetes mellitus, one of the very hot area, even the cardiac diseases, and also even for the neurological disorders like Parkinsonism and all the Alzheimer's disease. So this is something which really has been happening in the past 2 years in the field of stem cell therapy. However, there is just to summarize, the autologous stem cells is safe without any ill effects and can be done. We have some good results in the single center trials from our center and also some of the other centers in the country and other places. However, the data from randomized trials still is awaited to say that this is really the thing which works. But in some cases, at least there's some improvement has been shown. And the cultured tissue-specific stem cells or the induced pluripotent stem cell, that is still in the process of so-called experimental. Still a lot of in vitro work is going on. And hopefully, in next couple of years, we will have more clinical data on this aspect, whether how much it works. Some of the issues which are likely to address is that how much dose of stem cell do you really need? How long they last, and how do you really can track them? What you are injecting, those stem cells, they are really going to the site of the injury, whether it's a muscle or it's a cardiac or it's a pancreas for the diabetes or other things. So that is one of the major issue. And what happens in the long run? Say after a couple of years, do they last, or is it the autologous recovery of individual person which can happen for that particular tissue? And even if you are doing in the lab, in vitro data, can you ensure a large scale production which can be used for the most people? So these are some of the issues which a lot of labs in India are working right now, and of course internationally also this is one of the very hot area. Now from this I will now take you to the haemopoietic stem cell transplant, which is something which I said where the whole field started in 1950s. And this is one of the concept some of you may have seen in your biology books, this particular that's how the haemopoiesis takes place. That you have a pluripotent, or you can call it multipotent. Sometimes we use this kind of terms interchangeably. So the stem cells, they have self-renewal, and they also give rise to the differentiating capacity. So can give rise to the myeloid progenitor cells and lymphoid progenitor cell. And we all are familiar that with under the effect of various cytokines, the cells, finally you have the neutrophils, you have lymphocytes, eosinophils, and monocytes. So this is the whole basic framework of hematopoiesis or haemopoiesis in the human body. Now, what we use in the stem cell therapy or stem cell transplant, these are the basically myeloid and lymphoid progenitor cells. This is what is believed, that these are, when we take the autologous stem cells, this is probably we are using these myeloid and lymphoid progenitor cell. So sometime people also use in the earlier literature the progenitor cell therapy, stem cell therapy. Now, some of the developments after the Second World War, one of the first one by Vance and Lalit, and when they demonstrated that in the mouse model that you could have the bone marrow transplant, so-called in the mouse model, can abrogate the effects of the anti-leukemic effects and also can abrogate the irradiation effect. And then there's some of the human trials were developed, and the major impetus in this area came after the discovery of HLA system, human leukocyte antigen or histocompatibility antigen, so which is the one system in our body which really tells you about the graft rejection, how any infection or anything, how our body handles. So that's what the concept came in 1968. And after this, the whole field has suddenly really developed and matured. And the first publication on this was by the Joseph Borten from University of Milwaukee in 1970, and they have collected data on 203 patients, and only 3 of them survived at that point of time. But these were the people who have refractory leukemias and who failed a number of lines of therapy. But they proved that proof of concept that stem cell therapy, if done, can result into the long-term survival, at least in some patients. And one of the most impressive work, or the pioneer what you can in the field, was E. Donald Thomas. E. Donald Thomas was one of the director of the Fred Hutchinson Cancer Institute, Seattle, and he was the person who did the huge amount of experimental work in dog models and subsequently the human trials. And he shared this Nobel Prize in 1990 with John Murray for renal transplant. So this was one of the major thing in the field of clinical medicine in those days. So if I just summarize the stem cell transplant, you can get the stem cells, your own stem cells, we call them autologous. You have syngenic, if you have identical twin, another twin works as a donor, you call it syngenic, or allogenic. So you have a HLA identical donor, which could be your brother or sister, or if there is no sibling in the family, then you can even get the HLA identical donor from the another person who is HLA identical. So this is called matched unrelated donor transplant or MUD transplant. So which is in fact more than 50% transplant today in the US, and almost close to that, nearly 40% or so in the Europe are being done using the matched unrelated donor transplant. And the source of stem cells could be bone marrow, where the field started in 1985, and I realized that you also have stem cells circulating, though a small proportion in the peripheral blood. So this could also be one of the source. Now, in fact, for malignant disorders, and I'll show you some of the slides, this is being used as one of the major source of stem cells. And now we also have the umbilical cord or placental blood as a source of stem cell transplant. The basic principle that how the bone marrow transplant or stem cell transplant works based on the 3 things. One, that you normally give them the high dosage of chemotherapy to the recipient, so basically to knock out the underlying malignancy if it is there, or in case of non-malignant disorders, the bone marrow which is dysfunctional, you want to really knock it out. And secondly, in case of allogenic transplant, where you want to take from brother or sister, you have to create a state of immunosuppression so that the donor cells can go and engraft in the body. And thirdly, also it's believed that you create some sort of space in the bone marrow, what we call a niche, where the donor cells, they engraft and subsequently start the haemopoiesis. The steps of transplant that when we do the allogenic transplant, we first identify a donor, which could be your brother or sister or anybody else if it is HLA matched, which you can do with the help of bone marrow donor registry programs which are available. You condition them by giving high doses of chemotherapy, which is the main treatment these days, and also in certain cases radiation. And subsequently, on a defined day, you put them the stem cells back. And then you wait for the recovery and they engraft. That takes about another 2 weeks. So roughly about 3 to 3.5 weeks the whole program generally takes. The HLA system, which so some of you may be aware that this is located on the chromosome 6. The two major classes, class 1 ABC we call it, and class 2 DR, DQ and DP. It's short arm and long arm. Now, the system is so polymorphic, the various antigens which we inherit from our parents. And you can see some of these pictures that the probability of finding an HLA match in a family is about 25%, 25 to 30%. So even we are born from same parents, still we may have it immunologically at the HLA system level, we are different. So this is the gene matching, or what we call it simply HLA matching, what we really look for the bone marrow transplant. Quite often people ask us, is this when we tell that we need to have a donor which has to be HLA matched, and they will come, okay, my group is matching, so it should be okay. No, that is not true. So group can be anything. It could be any B, A or O, any combination could be there, but it has to be an HLA identical match, which ideally should be available in the family, but sometimes there, sometimes not there. So then you have to really look from the bone marrow donor registry. And various methods which are being used, they are very sophisticated because so much polymorphism. So to avoid the reactions, so at the best perfect match, if you really have, the chances of post-transplant complications are very, very little. So that the number of techniques are available, and this is one of the method which being used in lab in our department of HLA department at the institute. And this is the PCR-based methods. How do we really do the bone marrow harvest? This is one of the, just to give you a little picture. Basically, it's taken under anesthesia from the donor is made to lie in the prone position, and you take from the iliac crest, from the hip bone. Generally, it takes about 45 minutes to an hour, and it can also do it on the outpatient's basis under spinal anesthesia. So it's not really, it's a very, hardly there is any complication. Donor may have some pain which may last for about a day or two, but generally it's very, very safe procedure, and even no short-term or long-term complications generally are seen. It's like it looks like a blood, as you can see this back here. You just collect repeatedly 5 to 10 ml each prick, and then finally you put into the bag, which can be then taken to the lab, and then you can do the counting. From peripheral blood, which obviously is much more convenient, what we do, we give them the growth factors, which are like a tonic to the bone marrow, and given for about roughly 5 days. And on the day 5 or day 6, you take them to the machine, which is so-called apheresis machine, and a number of models are available, different kind of machines each hospital will have. And on this machine, like you make them person to donate. And then with the help of these disposable kits, the machine, the centrifuge will kind of make all these things separate, the red cells, plasma, platelets, and so on and so forth. And finally, you will have the stem cells, about 100 to 120 ml, which will be concentrated as like blood in the separate bag. And then you can just take the blood, rest of thing goes back to the donor. So absolutely, again, takes about 3 to 4 hours, but very simple procedure except the one prick, there are no really complication in that sense. And for umbilical cord, like just more of elective procedure, you at the time of delivery, like sometime we have the family where one child had thalassemia, mother is pregnant, if an antenatal checkup is done, there is no thalassemia into the newborn, and you can do the elective delivery, collect the stem cell, the umbilical cord. You as you shown, that's on the first cry you put the clamp and then put the needle into the umbilical vein and let it flow over. And or you can see here, like you can just hang the placenta and then just connect with the nip with the needle, and it will come into a small bag which contains the ACD solution so that it doesn't clot. In fact, umbilical cord blood is even more powerful because these are the most nascent cells which are the very, very potent compared to the adult stem cells. And second, one of the major plus point here is that umbilical cord blood, that they are immunologically very naive. So the chances of post-transplant reactions, what we call it graft versus host disease, which I'll show you some pictures here, are very, very little with the umbilical cord transplants. The only limitation is that since you are collecting a small amounts of only 60 to 80 ml, which generally on an average, which you get, so therefore this is more useful for the children who are 25 kilo or less body weight. Therefore, for adults nowadays, number of trials have been done and they have compared the bone marrow versus umbilical cord. The data, the results are similar. There you can, rather than one bag, you can use 2 bags. So that has been shown. That is what being done. And after the stem cells have been collected, they are taken to the lab. You can freeze them. We have to, like either use short-term freezing or long-term freezing. If you are planning to do it within a week or so, you can just put them into the -80, mix with a cryo mix, which is like a DMSO, aluminum and saline, and it's a kind of mixture. You just put 1-to-1 ratio, and you can just put them into -80 freezer, and they are absolutely safe. In fact, up to 5 days, we have shown that up to 5 days, you don't really need to even freeze them. So sometime we have to give the stem cells within the next 2 or 3 days. We don't even freeze them, and we still have the same viability, 93%, 94%, which is reasonably good enough. But if you are planning to store them for long-term basis, like you may need it, say, after a couple of years, then you can use the system of liquid nitrogen, which is like, which can keep the minus 190 to minus 220 or so. And there they can be kept at the long-term basis. And once you have done the conditioning, patient has received chemotherapy treatment, subsequently you have to give the stem cells. So the initial period, whenever you start a stem cell transplant program, you want to really see how your stem cell quality is. For that, you put them into the colonies and see the colony quality, counting, and other so and so thing. But once the program generally is going all right, generally you don't need to do read because it takes little time, about 5 to 7 days or so. But this is one of the ideal method that you are able to really demonstrate that these are the proper functionally cells are okay. And what normally we do nowadays and world over is done is that these stem cells, once you take a sample, you do with the help of flow cytometer, you can count the number of CD34 cells, which is one of the marker for the stem cells. And if you stain them, this is how they look like. On your extreme right, you can see the large cells look like a big lymphocytes kind of thing. So these are the stem cells on the GIMSA stain. The various markers which are being used in the lab, but for practical purposes we use only the CD34. The other markers you really want to have absolutely pure population, then you can use the CD34 positive and CD38 negative cells, which will finally give you the real pure the stem cells population. And we normally have a kind of certain numbers which we normally say that okay, the stem cell collection is all right. For this is the number for bone marrow and peripheral blood. So generally about 2 to 2.5 in 10 to the power 6 cells per kilo of the recipient's body weight. That's what we collect. And for umbilical cords, they're very much more potent, so the number is much smaller. And these are the various regimes. I really don't want to get into this, but the concept is that you really give the alkylating agent which have a dose response relationship, which you have come across, known by the over the number of years, which particular drug can give you the best effect, which are used for both malignant as well as the non-malignant conditions. What has recently happened in last 15 years or so, we have more of lymphoablative protocols where you have more of knocking out of the lymphoid system rather than the myeloid system. And fludarabine is one of the key drug as a combination we normally use along with the alkylating agent like busulfan. Now, these are some of the pictures like central line. Since once we do the haemopoietic stem cell transplant, we want a line which is stable. We don't have to keep on repeatedly making pricks. So this is one of the line we put on the subclavian vein. This is called Hickman catheter, but there are a number of central lines are available. This is done under local anesthesia, simple. So I mean, this is something as a routine. We normally do it for all patients, so it's not a really thing. And when we have to infuse the stem cells, if you are taking the bone marrow, since some of the plasma will come, and so if there is group mismatch, then we have to remove that plasma, so there is no antibody, so that hemolysis does not take place. In case of peripheral blood, which we are collecting with the help of apheresis machine, generally this is not a major issue because the number of red cells is very, very little there. So then you can just take it out, bring it to the room temperature in a butter bath, and then subsequently you can reinfuse like the blood transfusion what you did. But that's another thing which many times people ask, are you giving it to the bone? No, this is given like any blood transfusion. So this looks like, you can't even say this is a stem cell. This is like a pure, looks like a blood, thick blood. And since patients have received chemotherapy, so they do receive antibiotics, antiviral and antifungal medicines as a prophylaxis. And those who have undergone allogenic transplant, since you want to continue immunosuppression for a couple of weeks, so that they do not reject, we have to give them the immunosuppression, cyclosporin and also methotrexate. This is what happens typically. When a patient is admitted in the unit, day 0 when we have given the stem cells, by day 5 the WBC count touches to 0, will remain so for almost a week, day 10 or 11, and then gradually start recovering. This is what the time you can call the maximum low counts period when they are prone for infections and other things. So all such patients have to be kept nursed in a separate room, what we call it the isolation room or single room. In fact, that concept nowadays has gone that you can just use the single room. You don't have to be strict kind of isolation room. And one attendant stays with them actually. And barrier nursing has to be practiced. So everybody has to wash their hands, use the mask and change the gowns and other things. And similarly, the platelet count also may be low, and for which they may need supportive platelet transfusion. I'll just show you one of the picture. Like this is the severe aplastic anemia. Severe aplastic anemia means, aplasia means there is no haemopoietic stem cells. So the blood counts are low. So they require frequent transfusions, right, to survive. Now this is the one pre-transplant. You can see the bone marrow is totally all fat. There are no cells, hardly any cells on the first left. And this is immediately on day 35, just after a month after the transplant. You can see the full of cells. All these red things which you are seeing, they are all haemopoietic stem cells, which tells you that this patient has engrafted very well and he's doing okay. Unfortunately, this gentleman who was about 39 years, he had received about 100 transfusions before he came to us. So he relapsed 6 months later, and we just noted his counts were getting low. We did the bone marrow, we confirmed it, and we have saved some of the stem cells frozen from his donor sister, who was 55 years that time. Fortunately, and we just gave him those stem cells with very minimal treatment, and then he again engrafted. Now almost 11 years, he continues to be okay. So these are the kind of thing which can happen. But this was one of those good things that this gentleman really made it. Some of the infections, because of the low counts, you can encounter which can happen. Some of the pictures like bacterial infections, you can have fungal infections, you can have in Candida like here, or sometimes the viral infection. This is one of the post-transplant picture which you see the herpes zoster. You can see the scar this gentleman had. And just some of the pictures again, the fungal infection, aspergillus, different forms, different timings which can happen. And the viral infections are particularly quite common, especially those who develop the GVHD or graft versus host disease in these patients. And so they have to be given the antiviral prophylaxis. And wherever we suspect, then we have to monitor for CMV viral infection, because reactivation which can take place. And if you don't treat, then they can develop the pneumonia, which can be very, very fatal. And the most difficult condition still today in the bone marrow transplant, especially allogeneic transplant, because this is the only will happen only in allogenic, not in autologous, when this is the graft versus host disease. And this happens because in spite of HLA matching, some patients, not all, some patients can develop this kind of complication, and it's because of the donor T cells activation can take place, and which may attack the recipient's residual tissue, like particularly in the skin, gut, and in the liver. And as a result, patients, and they release a huge amount of cytokines like TNF alpha. And I'm sure these kids must be knowing about the TNF alpha, what it can do. Some of those difficult things can cause a lot of injury. The cells may undergo apoptosis. Person may have a lot of diarrhea. Similarly, the skin can just peel off. So some of those things can happen with these release of, and it's also called cytokine storm. That's one of the most, if it becomes severe, it can be one of the most difficult thing to handle. Now, just to show you some of the pictures, like this very, very early kind of thing, some sort of macula, very light erythema sort of thing in the mouth. And in this picture, if you see this, like more of a peeling of the skin. So it's like what we call it the grade 3 kind of thing. This can be difficult. And sometime, like beyond 3 months, when the patients can have superficial ulcers in the mouth, which could be part of the GVHD, graft versus host disease, which some of these, if they are mild, in fact, they are supposed to be good, because they keep your disease also under check. This, especially for malignancy, this is one of the good things. But if it is very severe, then to control it, you have to use a lot of immunosuppression, which sometimes can flare up the infection. So that can be one of the difficulty which can happen. And sometimes you can have very rough skin, very thorny kind of thing, which can happen. How do we really find out the stem cells which we have injected? They are now working. Now this is one of the simplest thing would be that you can do the group matching, like somebody got a different group. You can check whether the group had changed. That's one thing which we do. But that takes about 2 to 3 months, because RBC half-life is about 90 to 120 days, right? So it will take some time before the group change can happen. Chromosome change can happen before that. And suppose if you have from male to female or female to male, brother to sister, then you can check whether XX or XY chromosome. So that is another simple way to think. But more important is to have the molecular methods, what we call it the short random repeats, and each individual have some of these nucleotides, the markers which can be identified. And if you do this, like this, the top picture on the right side is the recipient. These are some of the markers which we have identified, and these are the donor markers. And you can see that in the follow-up, he continues to have the donor markers, like 226. While on the other side, on the right side, you see the recipient marker is back again in the bottom picture, which tells you that the patient is rejecting or relapsing, the disease is relapsing. So if you get this information, like I showed you the picture of aplastic anemia, in situation like that, if you can demonstrate that the donor cells are now depleting and the recipient cells are coming back, which are disease cells, then you can intervene at that point of time rather waiting the full-blown clinical picture to relapse to happen. That may be difficult to treat. So that is the one technology which really is now available to most of the places and being used routinely for monitoring these people. Just to give you like some of the results, like the transplant activity, the worldwide, the autologous and allogenic really has gone up like anything. The field when it started in 1980, you can see the number of cases. Now almost nearly 25 to 30,000 patients each year undergo allogenic and autologous transplant internationally. Now these are the different indications, both malignant conditions and non-malignant conditions, where the haemopoietic stem cell transplant being used. And these bars, the green ones, they are for the autologous, and the dark blue ones are for the allogenic. So for acute leukemia, we normally use the allogenic transplant, while conditions like myeloma, lymphomas, we normally use the autologous stem cell transplant. And similarly, we have aplastic anemia, thalassemia, beta thalassemia, which is again one of the common problems in our country, and many other non-malignant conditions, particularly in children. Some of the congenital disorders, generally we use the allogenic stem cell transplant. Just to give you some of the results, like for individuals who are less than 20 years of age, if you do the transplant as soon as you make a diagnosis, you can expect almost 90% long-term outcome. This is something, if you do not treat such patients, only 10% survive beyond a year. So this is one of the major change which allogenic bone marrow transplant has brought in the conditions like aplastic anemia. So it's very important that the physicians who look after these cases, as soon as they diagnose, they should refer to the center where the transplant is being done. If you delay too much, by the time they pick up infection or they develop antibody because of repeated transfusions, the results can be poor. Beta thalassemia, again, once the diagnosis has been made, if they are minimally transfused, they have less amount of iron. If you give repeated transfusion, the iron deposition takes place. And they can have the spleen enlargement, they can have fibrosis in the liver, and based on that, the results can be compromised. So if you have minimal transfusion, then you can expect almost 90% outcome in the thalassemia for the class 1. But those who have been multiply transfused, say beyond 15 years, 16 years, by the time they have got every 2 weeks, then the results can be much lower as low as 60%. This is another situation like acute myeloid leukemia. You can expect almost nearly about 55% long-term outcome. So the stem cell transplant does improve the outcome for many diseases, for many conditions where the results have been very, very low with the conventional treatment. But again, this is not like that you'll have 100% outcome in conditions like this. Chronic myeloid leukemia, which is another common leukemia we come across among adults. Fortunately, now we have a better medicine, so transplant really has gone down. But in the earlier days, when the transplant was being done, almost 60% of people could have been expected to be long-term survivors following transplant. At the institute, in the department, we have done about more than 1,000 transplants till about 2 months back, which includes about 800 of auto transplants and 200 plus allogenic transplant, and includes about 9 umbilical cord transplants. Just give you little indications, like similar to the data I've shown you, acute myeloid leukemia, CML being the commonest one for allogenic transplant, and then some of the other conditions. In autologous transplant, we have the data maximum on the multiple myeloma. We have probably about nearly more than 250 patients, which we have done so far. And then we have Hodgkin's, non-Hodgkin's, and other malignant conditions, and some solid other tumors. For children, also we have done transplant for AML, lymphomas, neuroblastoma, one of the very common solid tumor among small children between 1 to 4 years of age, and also Ewing sarcoma or PNET, what we call it. Just to give you a little, this is multiple myeloma. That's one of the area which I personally have interest. These are the various how we really diagnose. You don't really have to bother about this. But this is something which really has happened in the last. Myeloma used to be a very difficult disease till about 15 years back. The median survival used to be about 3 years, 3.5 years. Now today with the transplant, those who achieve complete response, you can expect almost nearly, overall survival nearly almost 40 to 45% at 15 years. So this really has converted this disease into the chronic disease where people can live very long with good quality of life, can carry out with their normal routine work. Now, so what really has happened? So one of the things I said for chronic myeloid leukemia, obviously one would like to have a pill which can really cure some of these diseases. Transplant is not something which people like to go by choice, right? So now this is something which has happened. Like if you follow this blue line, in 1990s it used to be the most common indication. And now if you just follow it, now this is the lowest here. Because we have a drug called Gleevec or called imatinib mesylate. This is the one drug where the median survival expected is 25 years. So therefore, obviously the transplant is being done only the people who do not respond to this medicine or who have relapsed and progressed. Otherwise, for most patients of chronic myeloid leukemia, do not need transplant these days. Therefore, these numbers have come down. The other thing which have happened, like when the transplant started in 80s and 90s, it was being done mainly for the young people. It was always assumed the complications are too many. People in the higher age group will not be able to tolerate. But if you see this trend here, like nowadays we have almost 40% of patients for allogenic transplant are above 50 years of age. Similarly, for autologous transplant, more than nearly 40% of patients, if you see the last bar, are more than 60 years of age. So age is now no longer a bar. Now people have enough experience, can handle some of these complications. So transplant, if indicated, can be done effectively even at the higher age groups. And the other thing which I said about the various sources of stem cells, like if you see the stem cells which are being used, in the earlier graph, like you have a small number of the peripheral blood, bone marrow, and umbilical cord. In the last 5 years itself, the use of umbilical cord blood for the patients who are less than 20 years of age has gone up, almost nearly more than 40% or so. Similarly, in the more than 20 years of age, peripheral blood is the main source of stem cells, but a small number, about almost 10% or so, do still receive umbilical cord as a source of stem cells. So even among the adults also, you can use the umbilical cord blood as a source of stem cell. Let me just take you to the, what kind of challenges we face in India today for this particular treatment. We are a huge country, big country with a huge population. The number of centers we have, you can see some of these numbers which I have written here, is still less than 25. And most of them being in the non-government sector. Very few centers are in the government sectors, so not in the reach of many of the people, or most people I would say. And imagine the number of these centers for such a huge country is very, very small number. What we really need at least many more good centers for in each state where the people can really go and they get the treatment done. There have been efforts to collect the data from different centers in India, like how the transplant work is going on in India. And this tells you that over the years, in particular last 10 years or so, the number of transplant activity has gone up in India. And we have now data, in fact, now in 2012 and 13, it's about 9,000 people have undergone transplant so far in India, which again is very, very small compared to like almost 45 to 50,000 people who undergo transplant internationally. These are the various indications, both malignant and non-malignant disorders, like 15% of them accounted for the hemoglobinopathies, which mainly the beta thalassemia. And these are according to whether they got allogenic from brother or sister or they got from their own stem cells. Now, what is more important here, I just wanted to bring to your this thing. Now, what is the major difference you find between these different things compared to the Marrow Registry India? Even these countries, like if you see the UK, for example, or US, or France, Australia, these are small countries with small population, German, but they have a huge number of bone marrow donor registry, more than 1 million, practically. So it's easier for them to find a match if it is not available in the family. And especially now in India, the trend being the small families, and even if you have a large family, you have only 25 to 30% probability of finding a match. So if you, now with the trend going that is you have a nuclear family or a small family, so it's very difficult if your child gets sick and needs a transplant to find a match, because there is no registry in India. So that is something which I think the people have to really look, that we really develop a kind of registry, at least for a country of 1.2 billion or more, at least have at least 1 million donor registry where we can find. And you can also imagine that kind of diversity which we have in our country. We have people like from all different parts of it's difficult for a person who is from North India to find a match in the Northeast region, right? Similarly, somebody from South India trying to find a match because so it's not only ethnicity, also the genetic level also there are a lot of diversity, a lot of differences are there. So the large registry is very, very essential so that we really can cater the need for our population in coming years whenever we need. And a lot of time we get calls, actually the mails and calls from the people from Indian origin who are staying abroad, child gets sick, develop some kind of complication, leukemia or thalassemia or something, and they're now looking, they're desperate, look for a match. And they think that we'll find in India, and they know registry. They feel very sad kind of thing. But then this story every time ends at that point of time. But this is something which I think, similarly like umbilical cord, with such a large pool, so many deliveries take place every day. If you can really develop a umbilical cord registry, which can cater to not only children but also the adults. And I showed you some of the data that how it can be done. So the other things apart from the centers and apart from the Marrow registry or umbilical cord blood registry, which is very, very key for future success, we also need to have trained more people, the physicians, nurses, technical staff for this. And of course the decision about primary treatment is very crucial. It's done very properly so that only not everybody needs transplant if they can be cured with the primary treatment. And of course the cost still remains one of the major issue. And if I just show you the one of the last slides, that I said that the probability of finding a match in the family is about 30 to 40%. But if you want to import stem cells from US, suppose your child is matching with one of the person in the US donor registry, the cost itself is 1.5 to 2 million US dollars, Indian rupees, sorry, 1.5 million to 2 million. You can imagine the huge amount of cost it is. If you do the transplant there, if you take the patient there and do the transplant, matched unrelated donor transplant, current cost in the US is 30 to 40 million Indian rupees, 300 to 400 lakhs, which obviously is beyond the affordability of, I think, most Indians. And if you do the mud transplant, unrelated donor transplant in India, this comes to about 30 to 40 lakhs so which just have been started in some centers have started this. And finally, I would say that stem cell transplant is not one individual's effort. It's a team effort. It's a team of people, not only the clinical side, which normally always get the upper hand because they are shown, because they are directly dealing with the people. But the people actually behind the scene, all these people in the basic sciences, the HLA, the chimerism lab, genetics, microbiology, pathology, and there's so many people who really indirectly helps you to really get to the final shape what you really see. And I think there's nothing better than depiction of this, that you really have, unless you have combine your efforts with your basic sciences and the clinician both as a team, so then only you really can expect that you develop a team like for bone marrow transplant, which really can come out with the results what you can see today. So this is the bone marrow transplant unit at our institute, which is a 10-bedded unit with single rooms. And finally, I'd just like to end it here. The medicine is an art of knowledge and wisdom. Thank you so much.
I'm sure Dr. Kumar will be happy to answer any queries and questions you may have. Yes, right? Sure.
जी बताइए.
Thank you, sir, for such a elaborating knowledge you have given regarding stem cell transplantation. So I wanted to ask that you are saying that first of all, taking peripheral stem cells, you have to give GCSF to the patient. What is the molecular basis of giving GCSF? Whether it is stimulating the stem cell proliferation or what kind of mechanism there?
Okay, this basically mobilizes the stem cells from the bone marrow to the peripheral blood. Normally you have about 1% of stem cells, circulating stem cells in the peripheral blood. Since you want more number quickly, so you normally give them the GCSF, which makes them to really churn it out, make to the, if you see in the terms of kinetics, your bone marrow blood counts goes up like 40-50,000. And if you see the CD34 count, normally what we do, like we give for 5 days, on day 4 we do the CD34 counts. Because some patients who have been heavily treated multiple times with the chemotherapy or radiation, they may not have adequate mobilization. So on day 4 we do take a blood sample, do the CD34 count. If it is adequate, then we do the harvest on the next day. Or if it is low, then we have to go for the different methods. We may have to give them some chemotherapy and then try to mobilize. Once you give the chemotherapy, actually then by day 10 or day 17, between that time there is surge of stem cells in the peripheral blood. That has been one of the observations.
Sir, regarding, you said that HLA matching is a very problematic. Sir, will it be a...
It's important, it's must for the allogenic transplant. It's not a problematic, but it's must. Without that, allogenic transplant cannot be done or it will not be successful. You will end up into disaster.
So I want to query that if we experiment, will it be a rational designing so that we take out somatic cells from the patient itself and give it Yamanaka factor so that it become induced pluralist stem cells, and then we can inject into the injury site. Will it be a therapeutic use?
That's what the concept is, and that's what probably should work. But like in a small number, probably you may not have those kind of immunological reactions. But like in Haemopoietic stem cell transplant, for example, if I take some cell then convert them to the bone marrow cells, unless I have a larger scale production and then inject, then probably, so that is something what I said, those are the issues. We still don't have the clear answer for them. We have to see over next 2-3 years if people come out with like what are the observations and how successful they are. Ideally, theoretically, single stem cells should be able to make your complete haemopoiesis. But that practically that doesn't happen because therefore you need that certain numbers. So
one last question. So the HLA match is, since 100% HLA match cannot be possible, so there must be a range of tolerance that you researchers have given, that 80%, 90%. What is that value that?
Okay, we normally like call it 6 out of 6 match or 10 out of 10 match. So like you have class 1 ABC and class 2 DRDQ DP. They are 2 different classes. So like if you are matching the class 1, the chances that class 2 matching is also chances that you will be matching. So normally we initially, earlier day we used to do the serology for class 1. If it's matching, then we used to go molecular matching. Adequate match in the family because you can trace out the father, mother, that so you know that what from the genes actually the genes are coming. Now, sometimes 5 out of 6 is also acceptable. The complication rate is very, very low. But if you go below that, then the risk of GVHD and rejection also becomes very high. So you may lose a person in that. I mean, some methods are now coming up. People are doing like haplo, that if you have only 3 out of 6 or 4 out of 6, you can still do the transplant, but those are still, I would say, in experimental. Results are not as good as you would have expected I've shown you some of the results. Those are with the sibling transplant. Those results which I've showed you, 90% of aplastic or 80% and 50-60%, those are with the HLA identical sibling in the family if you do the transplant. Obviously, the results from the unrelated donor transplant or haplotransplant half match, the results are definitely inferior as of now. But let us see the technology improves in the future.
First of all, attitude of gratitude. Many, many thanks for the wonderful lecture. Sir, I have 3 questions. My question number 1, as you mentioned that stem cell transplant can be used for multitude of purpose. So what are the actual conditions where it is most effective?
Okay. Like if you go to the let me just show you the now. All right, I don't know. I'll just tell you. But now, for the two things we are now. So I said the stem cell therapy separate. Let me just keep it separate. I'm talking of the haemopoietic or bone marrow stem cell transplant. Okay. Now, bone marrow stem cell transplant, you can call it in the two categories. One is the malignant conditions, second is non-malignant conditions. Among the non-malignant conditions, the commonest one is severe aplastic anemia, and the second commonest in this part of the beta thalassemia, which is more common here, not in the Europe or not in the US. And then we also have certain congenital metabolic disorders in children, like Hurler syndrome and those kind of things where it is used. We have some limited experience with those conditions. Now, in malignant disorders, we have acute leukemia, AML, and I think it's gone. Maybe, anyway. So, we have acute leukemia, AML, acute lymphoblastic leukemia, and then we have myelodysplastic syndrome. So, these are the allogenic where we normally use it. Then we have in the autologous, where the multiple myeloma, Hodgkin's, non-Hodgkin's lymphoma. I would say these are three important things to remember. That where we have enough data with plenty of randomized trials which have convincingly shown that transplant improves outcome compared to the non-transplant therapy.
Okay, thank you, sir. My next question. About a month ago, I read in an article of Times of India that stem cell can or may cause cancer in himself. Is it, we do any follow-up after stem cell therapy? What is?
No, actually that is in relation to the stem cell therapy. So if you remember my first picture, the embryonic stem cell, there is a very small potential risk which people thought theoretically because this is making all the germ layers, so teratoma. But over the years, many people have been using, even in vitro, they really not been found true. So there is particularly, I would say there is no really risk.
My last question, yesterday was World AIDS Day, and we know that in HIV, CD4 counts are decreasing. So is there any study in AIIMS or abroad using stem cell for this manic disease?
To best of my knowledge, in AIIMS there has been not, but in US I think one patient of HIV positive underwent stem cell transplant. In those cases you don't need any immunosuppression, you don't need any conditioning, you just simply take a stem cell and then you give it. This person recovered. Unfortunately, and I think he was alright for about almost a year. Recently, just about a month before, there was a news item that he has relapsed again.
Okay, thank you very much.
Thank you for the lecture, sir. Sir, as a physician or treating patients at Periphery, I would like to ask that you mentioned that we should refer the patients of the indications as soon as possible for stem cell transplantation. So right. When while treating somebody with the aplastic anemia or maybe say beta thalassemia, when should I ask them or when should I tell them to, okay, you should consider this therapy also, and right. This is your end here and you should be referred to a higher center.
Okay. Severe aplastic anemia is the only emergency which patient need to be taken on the emergency basis for the stem cell transplant, because like there the marrow is like very low cellularity, the counts are very low, and if you do not treat them, they may pick up infections and may finally die. So those are the situations. As soon as you make a diagnosis that he's got aplastic anemia, this child, and severe aplastic anemia, rather than doing a multiple lines of hits and trials, it's better to send to a center which is at least have experience of handling the aplastic anemia. So there is minimal antibody formation because of repeated transfusion and platelet transfusion which they need. And once the HLA matching is done, as soon as it's done, then you should be taken up for transplant if they may have a match available. Because that is the best treatment and outcome can happen in aplastic anemia. Beta thalassemia, generally, I would say once the child is diagnosed, between 2 to 4 years, if the match is available, is probably ideal age. Something below 5 or 6 years is the better. Because as the age keep on growing, the requirement for blood transfusion keep on increasing. So anything beyond 10 years generally becomes very difficult by the time they have a huge amount of iron in the body, which can damage a lot of organs.
Thank you, sir.
Remember.
Can I? My question is, just I will be asking simple. Have you got some experience of Duchenne muscular dystrophy and stem cell therapy?
Okay, we in fact did 2 children with Duchenne muscular dystrophy. We were not very keen to do it. One of them was related to one of our faculty member, and she herself diagnosed this child in their family, and the child had a match, so we said, okay, we'll try. But he recovered and all that, but for about 3 months we thought maybe some improvement was there, but finally it was autologous recovery. Second child we did about 6 months back, but again everything went well. Some improvement on the CPK enzyme and in the PET scan imaging, also some decreased activity in the muscle, but finally it's autologous recovery actually. The chimerism gradually went down. So I think for Duchenne muscular dystrophy, still we do not really have an answer. Maybe unless we take out the muscle and culture and then especially inject and something like that has to be done. So I'm hoping that stem cell therapy will probably get a better answer for us, but not the allogenic transplant as of now.
Thank you for the nice lecture. Sir, what is the rate of success in case of diabetes, stem cell therapy in case of diabetic person? Because a lot of person they are just willing to know.
Actually,
and what are the risk factors?
There are number of reports, actually I did not include it here, number of reports which are available for type 2 diabetes, where people have used either using the bone marrow stem cells, injecting that locally into that area, and they have shown that the requirement for the insulin or other anti-diabetics came down. But then those are like single center studies, and it's not, it's like about some, say 4 out of 10, something like that, some improvement. Some got 1 or 2 out of 10 got completely off the therapy, 1 or 2 got little reduced half of the dose. So far we really don't have kind of answer. We don't have an answer from the randomized trial which can say convincingly that okay, this group does better compared to another group. That is something, but
There is some report from the PGI Chandigarh.
in fact at AIIMS also they have done some work about 10 or 15 cases. In initially 1 or 2 cases they felt that there was very encouraging results, but subsequently somehow it got plateaued kind of thing. So I would probably wait for some of the time. In fact, there are large data published from the Brazil. They have been able to do it. But again, this is a single center study, and again people are not very sure whether it's really long term, whether it lasts. Because many times what we read is that the quick results, people come out, okay, we have made something, and suddenly comes. But when you see the follow-up after 3 years, 5 years, 10 years, then you suddenly results are not sustained. So that is some problem. But this is one of the very, I think people are really worried if something can be done.
Sir, मेरा question ये है कि is there any treatment for celiac disease persons so they can get rid of GFD, gluten-free diet?
Not from the point of view of stem cell transplant.
Allergic reaction. In general, allergies will be addressed.
So as of now, so I think gluten-free diet ही आपको रखना पड़ेगा, and you have to find the triggers which can really precipitate some of those things. So I think हमारे यहाँ celiac disease clinic एक चलता है वहाँ पे AIIMS में, and there seems to have a good number of patients, and I think they seems to be doing quite all right in that sense.
Questions, take it back, please.
Sir, thank you very much for your nice lecture. I have been a patient of spinal cord injury for last 24 years. Is there any research being done on stem cells by recovery of the spinal cord?
Actually, if you remember the Superman, or so I think they really donated a huge amount of money and a lot of research being done. But as of now, I would say this is experimental. In few patients, the reports were published that there was some good response, patients started improving and all that, but then it did not sustain. They have done few cases at our center also, but and all these were done with the autologous bone marrow, which because that was something ethically permissible, so but did not really end up into very good long-term data. So unfortunately.
We just have some questions from students.
So thank you for a nice lecture. So I myself has a twin. So can you tell me something about the success and complications of syngeneic transplant during the cell?
Okay, syngeneic, because twins are like 1%, so syngeneic transplant more or less like a autologous transplant. So syngeneic transplants have been done. In fact, we have done 2 syngeneic because they were the twins. So the short-term results are same, what you see. In the long term, there is a risk of having relapse of the disease. So that kind of problem. So then in that sense, they are like autologous. Because autologous, that is one of the problem. I did not show you that slide. Because we are giving those same cells, especially in malignancy, for example, because the risk of reinfusing those cells, which are malignant cells, even very small in number, even the person is disease-free at that point of time, they could be very dormant, very small number of cells which may be there in the graft, which you have reinfused, so which may give rise. People have tracked those stem cells, and they've shown that these were relapse was because of those. So syngeneic in that sense not able to mount up the T cell response. Actually in the body what we need a T cell response to really fight out this thing. So syngeneic lacks that actually.
So Lalit, sometime back penicillin was one of the main treatment for all types of disease. Now stem cell is the one of the substitute. Do you think the cost will continue like this, or you will cut down to cost? Because you can have something like animal stem cell to transfer, is it possible? Or you can have synthetic stem cell for this disease?
No, actually the stem cell transplant cost, if you do in India, if you have more centers, the cost really is much down. In fact, for multiple myeloma, like autologous, in our center, the cost may just come to about 1.5 lakhs, 1 to 1.5 lakhs, which are really nothing these days. So even for allogenic transplant, the cost at our center, we normally give the estimate up to 5 lakhs because you need some immunosuppression, which they have to take for 6 months or so. So, but doing it same transplant abroad, basically, the costing and other things are much different way actually looking at things. So you have more centers and able to do the transplant here in India, that will be much simpler. And of course, like where you need to do the transplant in the diseases where you do not have other option, that is so not the stem cell has to be done for everything. No. So stem cell transplant is an important method of treatment, but it's not a panacea for everything. That's what we have to remember. So we have to find out what are the really appropriate conditions where the results are available, where the results are better than the conventional treatment, and then only we should do it. If we just keep on saying we want to do a stem cell transplant, then obviously the long-term results will not be there. I hope I have answered your question. Sir.
I think one more question.
Thank you very much for your elaborate lecture. I want to know, you just told us that stem cell therapy can be used for eyes. Can it be used for macular degeneration of retina?
Yes, sir. Actually, I was involved in the initial years in 2005 when they started till almost 2010. They did a dissertation also in the Department of Ophthalmology. They did find some improvement. I won't say they did not find any improvement. They did find, because I used to take out the bone marrow for those patients. That's why I know it. So the bone marrow was being done in our department, and they were injecting there in the OT, in the ophthalmology department. So, but subsequently they had to stop the trial because ethical permission was not given. There were some complaints and other things, so the trial got stopped. But there have been some data that in some patients, not in all, the response did take place. So what is important really to find out who are those people who benefit more than the others. So you can be very carefully select those cases. So it can work in them. Dr. Atul Kumar was involved in those.
I must say, wonderful, excellent. My question is more related to one of the challenges which you mentioned, that from the umbilical cord, you get only 60 ml of sample.
60 to 80
Now,
ml.
India being a huge country, and now you've got a lot of centers all across the country. And whatever the deliveries that occur in rural areas, that umbilical cord goes waste. Now, under NRHM, they got huge money allocation. But if a suggestion from a person like you goes to them, they can create an arm by which sample collection or sample preservation from those deliveries can be a big asset.
Yes, sir, absolutely. You're absolutely right. That's why I simply said this. It's not only rural areas, actually in the Delhi itself, you have such a huge major hospitals like our own institute, Sibling Hospital, which caters a huge number of people, and there is not a single delivery the umbilical cord is stored. They just simply thrown away. In private sector, we keep on listening that they are preserving their umbilical cord by 25,000 rupees or X amount of rupees, which is again based in the sense because you probably may not be needing it. What basically you need, this kind of bank, if they are available, then this can be need for the other people. This need can be met for those people who need it. So ideally, each umbilical cord should be stored and typed and kept in the properly. Then this can be more useful. So I think really the people in the government level or political level, they really have to emphasize, and some people really have to take initiative, because this will really need the HLA typing of those samples, proper quality and all those things. So it needs a little effort. That has to be done. But that you are absolutely right. That has to be done.
Good evening, sir.
Last question, and otherwise we can continue discussion at the tea time.
There are two questions, sir. Can the stem cells be reused after the failure of the stem cell transplant?
Yes.
Or the same.
One example I gave you, like the patient of aplastic anemia, the picture I showed you, that who relapsed after 6 months, and then we had stem cells frozen earlier from the earlier transplant, so which were, and then we reused them. We used the same from the previous thing. So that's one way to answer that. Secondly, like we have another patient of aplastic anemia. This is a large family, about I think 6 or 7 brothers. So he had a match with one of the brother and sister. Sister was just married, so the father wanted to we'll take from the brother, but it turned up. So we did the transplant for him. He unfortunately relapsed after I think about a year and so. Then subsequently next time we took from the sister. So this time this buck, and he's now I think almost 8 or 9 years. So that is one way to do that.
So one more question. If a patient is having a ruptured retina since birth, if that stem cells can be used for the regeneration of retina?
I'm not sure I really can answer that question, but there
is
a condition called retinitis pigmentosa, which is one of the congenital conditions where so we have done a small study by Dr. Atul Kumar, who is in the Department of Ophthalmology. They did a study in the retinitis pigmentosa, and what they have shown is that there is some improvement in the evoked potential and other things, but not at the clinical level. So I don't know whether stem cell will work for the retinal detachment or from the birth. I think I'm not too sure. I mean, I really have to ask them.
Thank you, sir.
I'm not thought about it.
As a token of our appreciation, I'd like to offer a shawl to Dr. Kumar. Dr. Kumar? Yes. I would like to take this opportunity to thank Dr. Lalit Kumar for a wonderful lecture. It was indeed very informative and educative for all of us. I'm sure there are many more questions. I also have questions, but then time is not permitting. But I think we're going to have a tea offered outside. And then if you would like to have any more discussion, he'll be available for another 15-20 minutes. I would also like to add that he gave us not only the current status of research of stem cell in India, but also traced the historical perspective also, and gave us some lot of information on that how this field came into existence. And not only that, we also have some understanding now that where do we stand as far as Indian scenario is concerned, and what more needs to be done, and what are the challenges facing this particular area. But with the kind of advances which are being made in science, I'm sure in the years to come we'll have much more success in stem cell research. And some of the areas and questions and kind of concerns expressed in audience also, they'll be addressed in the years to come. Thank you very much once again, and let's applaud Dr. Kumar once more. Thank you. I would also like to take the opportunity to thank Mr. Sahni, Dr. Alok Moitra, and also the staff of INSA for having organized the lecture and also giving all the assistance for the organization of the lecture. Thank you very much, and I invite all of you for a cup of tea in the adjoining hall. Thank you.